Hello, this is Sam Chen. I'm Associate Professor of University of Florida, Medical Director of UF Pediatric Intestinal Rehab Program. Today I'm going to talk about diagnosis and management of pediatric short bowel syndrome. Short bowel syndrome is a rare but a really debilitating disorder, a serious state of malabsorption. It is most commonly caused condition and cause intestinal failure in children. It occurs after resection or loss of a major portion of small bowel due to congenital or acquired reasons. In pediatric patients, short bowel syndrome is defined by either the need for parenteral nutrition for 6 weeks to 60 days after bowel resection, or a residual small bowel length of less than 25 to 30% of expected length for age. It is usually caused by congenital defects such as intestinal atresia, stenosis, gastroschisis, or even Hirschsprung disease. It can also caused by necrotizing enterocolitis. That's one of the most common cause, or midgut volvulus. Therefore, the most majority of the pediatric short bowel syndrome occurs at birth or shortly or earlier during earlier infancy. Regardless of the etiology, children with short bowel syndrome cannot absorb and digest food normally. Consequently, patients with short bowel syndrome often present with malabsorption signs and symptoms. So in short bowel syndrome, every patient is different, and you will never see two patients alike. However, based on the anatomy of remnant bowel, short bowel syndrome can be classified or categorized into 3 general types. Type 1 is endojejunostomy, and patients have lost most of the small bowel, as you can see from this slide, and the entire colon. So patients under this category can get dehydrated very quickly, and whatever they eat comes right out. So this patient has the worst outcomes. In type 2 is the jejunal colic and anastomosis. And then although this patient can do very well also, and most patients have weight loss and severe undernutrition, and which can last for months to years. And type 3 is jejunal ileum and anastomosis. This patient seems to do the best. So patients with short bowel syndrome often have also intestinal failure. So what is intestinal failure? So intestinal failure describes the failure of intestinal function, unlike short bowel syndrome, which is used to describe more about the failure of the anatomy. So intestinal failure occurs when the intestine does not properly absorb and digest food normally. Intestinal failure, because of this, so patients with intestinal failure and short bowel syndrome often have excessive fluid and electrolyte losses, inability to absorb adequate energy and macronutrients, and inability to absorb vitamins and minerals with a poor growth, and then failure to thrive, intestinal also dysmotilities, dilatations, and even stasis. And patient often requires IV nutrition or total parenteral nutrition due to inability to maintain fluid, electrolytes, and nutrient balance. According to the severity of intestinal dysfunction and whether acute or chronic, intestinal failure can also categorized into 3 types. Type 1 is acute, short-term, and usually self-limiting conditions. Patients under this category usually requires TPN briefly only for a few days or few weeks. In type 2, patient usually has a prolonged acute condition patient usually metabolically stable, and then requires complex multidisciplinary care and parental nutrition support over a period of weeks to months. However, in type 3, patient usually is a chronic condition. Also, patients metabolically stable, and they are usually require parental support over months to years. So what happened after bowel resection? So intestinal adaptation occurs. So intestinal adaptation describes the physiological change to the remnant bowel. It begins after after bowel resection and typically lasts 1 year, 1 to 2 years, or even longer. 3 treatment options can be used to facilitate the adaptation. That is nutritional therapy, pharmacotherapy, and surgery. This will be discussed later in more details by Mr. Stewart, Dr. Farm, and then Dr. Taylor. However, what I like to emphasize here is provision of oral and enteral nutrition is the foundation. It stimulates the crib cell hyperplasia, villus hypertrophy, and then enteral hormone production and pancreatic secretions. As a consequence, the intestinal surface area increased, and the cribs deeper and the villus taller, and then as a result, the intestine become longer and wider. Also, both short bowel and the colon can undergo adaptive change to accommodate anatomy. The ileum is the most adapted. It can even undergo colonic cell manipulation, followed by colon. Also, colon has the potential to develop ileum cells. And the jejunum has the poor adaptation potential. The predictors for successful intestinal adaptation, including the length of the remaining small bowel, the presence of the colon, and the presence of ileum cecal valve, and then the low bilirubin as also predictors. So patient with short bowel requires parental support. So while this parental support provides important nutritional support necessary for maintaining health and growth, and also providing time required for intestinal adaptation, it can also generate many complications. So IFAD, so intestinal failure associated liver disease. This mild liver dysfunction is very common and can be seen in as much as 30 to 40% of patients with short bowel syndrome, IF, and on TPN. Also, most of this will resolve over time. Approximately 20% of these children with IF and TPN will develop liver failure. However, this number are actually declining due to the improvement in TPN, and particularly after the introduction of the new lipid emulsions. The typical change, pathological change associated with IFAD, including steatosis, steatohepatitis, and intrahepatic cholestasis. Not every patient will develop the liver disease. So the risk factor for the development of liver disease, including prematurity, low birth weight, and the length of remnant bowel if it's too short, or will have more chance to develop liver disease. Duration of TPN, of course, that's the common reason, and sepsis, and lack of enteral nutrition. However, when liver failure develops, patient will need a transplant or liver transplant, a small bowel combined liver transplant. Another most common complication associated with short bowel and intestinal failure is the small bowel bacterial overgrowth, SIBO. And then the consequence associated with small bowel overgrowth will be food allergy and eating disorder. Patient have a bad appetite, poor growth, and cholestasis, and also liver fibrosis, cirrhosis, and venous atrophy, malabsorption, and even increased permeability leading to IBD. The third most common complication is the Cryptopsy, catheter-related bloodstream infections. And this is a serious complication and can be life-threatening. In some patients, it can happen as frequent as once every month. And this frequent occurrence of infection can also lead to loss of vascular access. This is one of the indications for intestinal and transplant. The critical preventative measures to prevent infection, including good parent education and caregiver education on how to properly handle the catheter, and standardize the protocol for catheter management. For example, always use antiseptic, antibiotics, locks whenever the catheter is not in use. So management patient with short bowel is complex and it is challenging. Because of this, patients with this chronic condition should be best managed by multidisciplinary teams in institutions with intestinal rehab programs. So Dr. Taylor, the surgical director of UF Pediatric Intestinal Rehab Program, will discuss more on this topic.
Thank you, Dr. Chan. Like you mentioned, I'm a pediatric surgeon at the University of Florida and the surgical director of the Pediatric Intestinal Rehabilitation Program. So why have one? As we know, it's a rare disease, but in certain places it seems like if you have a location, if you have a center where this is what the clinicians and the other care providers focus on, then these patients can actually have much better outcomes, clinical outcomes, and better quality of life. The patients are very heterogeneous, and they all, because of this, require very individualized care. It's not really a one-size-fits-all approach. NAPScan, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, recommends that patients with short bowel syndrome on parenteral nutrition for greater than 3 months be referred to an interdisciplinary intestinal rehabilitation program for consultation or management and evaluation of their overall state. The goals of these multidisciplinary teams are many. It's to provide support of growth, nutrition, and overall patient development, really prioritizing and pushing for intestinal adaptation and enteral autonomy. You might hear of intestinal failure programs as well, and we all have the same goals, and a lot of us focus on the more optimistic side, that we are rehabilitating these patients, and they do have intestinal failure, but we're trying to get them off their parenteral nutrition. The other thing that we focus on is early treatment of complications, and a lot of patient and family education goes into a lot of what we do. We provide continuity of inpatient and outpatient surgical and medical care so that it's less fractured and these patients can get the care that they need because, like we've referred to many times, they are very complex. And if needed, provide transition to intestinal transplantation, either within that same home institution or to another facility at the appropriate time. And another thing that we do as multidisciplinary care teams is we do everything we can also to advance the field through outreach, collaboration, and research. So at minimum, to have an intestinal rehabilitation program as defined by NAPScan, a program needs a gastroenterologist, a surgeon, a dietitian, and a nurse. This next slide shows you the overall, the real big picture. This is your wish list for your intestinal rehabilitation program, to have all these, have all the input and expertise involved of as many care providers as possible. The benefits. These interdisciplinary teams provide improved patient outcomes and overall survival that has been showed in multiple large-scale as well as regional studies. NAPScan themselves reviewed outcomes and have shown that there is significant reduction in the number of septic events per 1,000 catheter days. There's a reduction in mortality rate from being on long-term parenteral nutrition. There's a reduction in mortality rate from end-stage liver failure and reduction in mortality rate among patients waiting for transplant. So even if these patients are not able to be completely rehabilitated from an intestinal health standpoint, they do better when they do go to transplant, when they are cared for by an intestinal rehabilitation or an intestinal failure team. So given all the aspects of care these patients need, a lot of times, having a social worker involved to provide the support that these patients need is critical. And Kimberly Iglesias will be reviewing psychosocial needs of these families next.
Hi, I'm Kimberly Iglesias. I'm a social worker at UF Health, and I'm just going to talk briefly about what a social worker can do on a multidisciplinary team, particularly when working with children that have complex medical needs. One of the main things that we would be doing is a psychosocial assessment and really looking at what referrals and services, education, mental health needs there might be with that patient. And also trying to bolster whatever natural support system that the patient has, as that can sometimes be missed. And then just providing anticipatory guidance regarding multiple medical appointments, insurance issues, things that a family might encounter or a patient might encounter throughout the course of having to get their medical care. Social workers can also be involved in a transplant evaluation process if that's appropriate for that patient, and they're going to be looking at whether or not there's any contraindications to the transplant process happening for that patient, or if there are, how can we maybe mitigate those things in order to proceed with having a successful transplant. So they're going to look at the social issues of what financial, emotional, cultural issues there might be, and really try to take any of those barriers and find resources to be able to get that patient the best care that they can get. Some of the common barriers to care are things like access to health insurance or insurance denials, and helping a family figure out how to break through some of those things and advocate for their child. Social Security process, there's a lot that comes into play with that, but it's an essential resource for a lot of patients who have chronic medical needs. And so helping walk a family through that, or what the appeal process entails if they do encounter difficulties in accessing those services. A lot of issues that people have tend to be financial issues. You know, if you have a child with a chronic medical illness, it might mean that you aren't able to work a full-time job because you're having to manage going to medical appointments and managing your child's care. And so a lot of financial stressors can hit a family. So what we do as the social workers is try to figure out what's the need, what programs are available, applying for grants or anything that's out there that's above and beyond what insurance can provide. Assessing for just simple things like transportation barriers, and finding resources to make sure that a child can come to their appointments on a regular basis. And then really anything else that encompasses what the life of that patient is. So if it is a food insecurity issue or housing issues, employment issues, legal aid, all kinds of things like that, is what a social worker would do to try to find resources and help in that care coordination so that the medical care can be as ideal as possible, and that those barriers can be things that hopefully we can work through.
I'm Daniel Stewart. I'm a registered dietitian. I work as part of the intestinal rehabilitation program. The main purpose of my role is to help with writing the total parental nutrition orders, managing enteral feeds, and eventually oral feeds as well, to slowly transition off of. Nutritional therapy and dietary recommendations must be tailored to the patient's age, body size, sex, lifestyle, eating habits, food preferences, and bowel condition. Every patient is different. There's no one rule that applies to all. Nutritional therapy for intestinal rehabilitation includes oral rehydration, parenteral nutrition, enteral nutrition, vitamin and mineral supplementation, a tailored diet to fit their needs, small, many frequent meals, and also a high-fat formula diet. With our short bowel children, we will see them initially every 2 weeks. As long as they're on parenteral nutrition, they will be seen every 2 weeks for labs as well as adjustments to the parenteral nutrition. After that, we will advance them to monthly. Once weaned from parenteral nutrition and seen monthly, we can then advance to every 3 months once we see that they have hit stability and they are tolerating the enteral feeds that we are giving. Over time, as they get older and they've shown more adaptation and more tolerance, we can advance to every 6 months and then eventually for our older children to yearly. The assessment when they come in, we assess not only their labs, but also their growth, any symptoms they may be having of abdominal pain, of discomfort, stool patterns, but also looking at the input and output, how much fluids and food they consume versus how many times a day they void, as well as overall nutritional status, looking at body fat. Evaluation of liver dysfunction and central line issues also occur at that time. After we visit with the patient, we will sit together as a team and we adjust and discuss what the current total parenteral nutrition RX is and adjust it as needed. Every 2 weeks to every week, we will run a CMP, a MAG, a FOS, and then triglycerides every 2 to 4 weeks until stability is reached. Once parenteral nutrition is fully weaned, we will change to monthly labs, then every 3 months, followed by every 6 months. Certain labs are only checked annually, like the INR. Certain labs are checked a little bit more frequently, like B12, iron, copper, that are a little bit more sensitive. If DEXA is at baseline, then we'll do every 1 to 2 years and instead of less often. When we attempt to transition a pediatric patient to enteral feeds, we go really slow. The question I'll often get asked is when to start, or what to feed, or what's the best mode of delivery, or the most sought after question that parents will want to ask me is when can I start feeding food? Well, the answer is it depends on the child. Every child's ability to advance feeds, every child's ability to be able to tolerate feeds will vary depending on the severity of their short bowel syndrome. For infants, I recommend as much as possible to provide breast milk in lieu of any other commercial formulas due to the hormones and the specific type of proteins found in breast milk. In situations where either 1, it is not tolerated, or 2, the mother cannot breastfeed, I recommend using elemental formulas due to the risk of allergies with other formulas. When weaning off parenteral nutrition, the typical way we do it in clinic is to gradually advance the enteral feeds, and as we advance the enteral feeds, we decrease the hours in which they are receiving parenteral nutrition. Another methodology that some may use would be to reduce the number of administration days versus the administration hours within the day. With doing hourly changes versus day-by-day changes, it carries a lower risk of dehydration and tends to be safer for the patients. Now, some parents tell me that they prefer to reduce days, and I understand and respect that. But due to the safety and effectiveness of reducing by hours versus reducing by days, that is the way we tend to do things. As we wean off parenteral nutrition and onto enteral nutrition, there has been instances, and it is sometimes necessary to substitute out the parenteral nutrition for simple IV hydration, whether it be normal saline, whether it be lactated ringer. as a way to maintain hydration without doing parenteral nutrition. IV hydration is safer long-term than parenteral nutrition. Enteral nutrition. The general principles for older children are to do small, frequent meals with separate solids and liquids. I request that they drink no more than 30 minutes before or after mealtime. We avoid caffeinated beverages. We emphasize oral rehydration solutions in combination with water. And then, of course, we tailor the recommendations for the child based on the GI anatomy. If they have duodenal resection, I'm going to look for high sources of iron, calcium, and B vitamins, since those will tend to be low with duodenal resections. With jejunal resections, we tend to see more malabsorption of carbohydrates, lipids, proteins, trace metals, as well as vitamins. With an ileal resection, it has the same problems as the jejunal, but also we see problems in B12, bile salts, and with fat-soluble vitamins. With colonic resections, we see difficulty maintaining fluid balance as well as electrolyte stability. The colon is the continuity. An optimal diet for a colonic resection is going to be a diet low in simple carbohydrates like sucrose and lactose, as well as low in overall fat that could lead to malabsorption. For kids that have jejunostomies, we limit simple carbohydrates and simple sugars. What we find for most of our patients that are having problem with loose stools or diarrhea is to add increased soluble fibers as a way to thicken stools. We also have with us today Dr. Angela Pham, who is an adult GI specialist who works as part of the transition as well as short bowel syndrome team, working with adults, whereas we work with children.
All right. Hello, everybody. I will be discussing the pharmacotherapy and treatment of short bowel syndrome. So my name is Angela Pham. I am an assistant professor here at the University of Florida in the Division of Gastroenterology, and I also direct the IBD program. And in tangential, I also see a lot of the TPN patients and short bowel syndrome patients due to management of TPN. And one of my main goals in intestinal rehab is to wean short bowel syndrome patients off of their TPN as much as possible. And so to start with, I'd like to talk about some of the medications that we use in treatment of short bowel syndrome. So in brief, there's many classes that we use. The first, we use antibiotics. One of those antibiotics is rifaximin. And that's due to the fact that whenever you have short bowel syndrome or a change in your anatomy, that can lead to dysbiosis or change in your microbiome. And as Dr. Chang had gone over, you can end up with small intestine bacterial overgrowth, and that is often treated with antibiotics such as rifaximin. Then there's also anti-diarrheal agents such as Lomotil or loperamide. Anti-secretin agents such as octreotide can be given subcutaneously or added to your TPN regimen. And then we have our bile acid sequestrants, which are either cholestyramine or cholestyramine, which will help with bile acid diarrhea. There are also choleratic agents such as ursodiol, which help prevent some of the liver side effects of TPN. Then we have our GLP-2 analogs such as Dupeclotide, which helps grow your intestinal villi. It's an intestinotrophic agent, and that will help us in our goal of weaning off of TPN as well. Then we have histamine receptor blockers, H2 receptor blockers, such as famotidine. And then we have our proton pump inhibitors such as omeprazole, which both decrease gastric acid secretion and decrease ostomy output, hopefully. And then we also have our recombinant human growth hormone. So to break down some of these medications even further and some of their side effects and why we use them. So acid suppression is often used in adults outside of short bowel syndrome, the most common being omeprazole and pantoprazole. We use omeprazole and pantoprazole as well as famotidine in short bowel syndrome due to the fact that you have increased secretion of gastric fluid. In patients, you can end up with upwards of 1.5 liters of gastric acid secretion or just gastric fluid in general. And anytime you can block those gastric secretions, that will lead to overall decrease in output. And so we will often maximize our omeprazole or pantoprazole as much as possible in trying to reduce gastric secretions. In terms of bile acid sequestrants such as colistin and cholestyramine, patients who have had major surgeries can end up with increased bile acid, and that is not absorbed. And this will lead to diarrhea due to the fact that excess bile that reaches the colon will lead to increased osmotic fluid release. And so if you sop up some of that bile acid, that will hopefully lead to decreased output. Next, we have octreotide. As mentioned, I often will either add this to a patient's TPN regimen, or we can use this in sub-Q fashion. I usually will start with a dose of 100 micrograms, BID to TID. The only thing that I would say to caution is this can hinder intestinal adaptation and then also increases the risk of cholelithiasis and can cause cholestasis. And then lastly, our antidiarrheal agents, which actually are what I use first, our first line in treatment to prevent diarrhea. So what loperamide, I will often use this. I'll tell patients to take it 20 to 30 minutes prior to eating, and this can be taken around the clock. All right, so to move on, one of the newest agents we have in treatment of intestinal failure and short bowel syndrome is Dupeclotide. Dupeclotide is a GLP-2 agonist. It is a glucagon-like peptide that is secreted from the L cells of the ileum and cecum naturally. And it is a potent intestinotrophic hormone, which means that it increases the crypt cell proliferation and survival, and therefore increases the blood flow to your gut mucosa. It also inhibits your gut motility and gastric secretions. It also induces epithelial proliferation of the small and large intestine, and it also inhibits death of the enterocytes or enterocyte apoptosis. There are receptors throughout the GI tract in the neuroendocrine cells, the myofibroblasts, and the enteric neurons. And whenever a patient has had a major distal small bowel resection or colon resection, this can then lead to GLP-2 deficiency. And Dupeclotide, what it does is it is identical to the native GLP-2, except for the fact that it has a substitution of alanine by glycine at the second position of the N-terminus, resulting in a more extensive half-life. It's approved for use in the US and has been approved since 2012, and most recently was approved for pediatric patients 1 year of age or older since 2019. The standard dosing is 0.05 milligrams per kilogram subcutaneously once a day. So let's go over some of the trials that have been done on Dupeclotide. So there was a phase 3 trial in pediatric patients that led to the FDA approval of Dupeclotide. It was based on a 24-week study, which covered 59 pediatric patients ages 1 to 17 years old. Patients were randomized to either Dupeclotide in standard dosing or 0.025 milligrams per kilogram per day. So the standard of care dosing was 0.05 milligrams per kilogram per day. The primary endpoint was to see the number of participants who achieved at least a 20% reduction in parenteral nutrition or IV fluid at the end of week 24. So what were the results of this study? It was found that 69% of patients, or 18 out of the 26 that were studied, who received Dupeclotide at a dose of 0.05 milligrams per kilogram per day, reduced their parenteral supplementation volume by 20% or more at 6 months. parenteral supplementation requirements were reduced by at least 23 milliliters per kilogram per day, which was about a 42% reduction from baseline. So out of all the patients that were enrolled, 38% of patients were able to reduce their parenteral supplementation infusion by at least 1 day per week. So that's pretty considerable. That's autonomy from parenteral supplementation 1 day out of the week. And then a further 12%, or 3 out of 26 patients who received the standard dosing were completely weaned off of their parenteral supplementation. And in total, the mean reduction in time spent on parenteral nutrition was 3 hours per day reduced. So some precautions about the use of teduglutide. So because it is an intestinotrophic agent, it does cause growth of any adenomas that are already existent in the colon. And that is more of a concern in adult patients, of course. So fecal occult blood testing is recommended prior to initiating treatment with teduglutide in children and adolescents. And colonoscopy is required if there is unexplained blood in the stool. So if there is visible blood or the patient has a positive fecal occult blood, they definitely do need a colonoscopy. And then subsequent fecal occult blood testing is recommended annually in children and adolescents if they are on teduglutide. Thereafter, colonoscopy is recommended for all patients who have been on teduglutide for a year, and then every 5 years thereafter while on continuous treatment, and if they have new or unexplained GI bleeding. And then I will give the microphone over to Dr. Taylor to cover the surgical interventions.
Thank you, Dr. Pham. So not every patient who has shortcut syndrome or intestinal failure is going to be a surgical candidate for some kind of intervention to make them absorb better, to make their bowel longer. So the things that we look at and when we start thinking about it are if we know that the patient has a short length of intestine relative to their age and size, and also what of their intestine is remaining, then the other thing that's important to look at is how dilated is it, and can we provide the patient with any options to create a longer length of intestine to allow the enteral contents to have more time to bathe those enterocytes and to provide more time and exposure to the enterocytes for nutritional absorption. So the first type of operation that I will describe is called, it's got two names. It's called the Bianchi, the eponym named after the surgeon who first described it, but we also call it the LILT, the longitudinal intestinal lengthening and tailoring operation. So the idea about this is that it reduces the caliber of the dilated segment that is undergoing adaptation and then increases the bowel length. And the way we do that is that you take the dilated length of bowel and you divide it longitudinally down its midline. So we take a stapling device and splitting the blood vessels as they come off the mesentery onto the underside of the bowel, and then we staple and divide this larger lumen into two smaller lumens, and then we take those lengths and then we anastomose them. We sew them to each other in an isoperistaltic direction. It's been shown that the residual bowel can increase by 50%. And studies looking at these patients have shown that as many as almost 90% of them can be weaned from TPN after the procedure. But these are very specific situations that you choose these patients for these operations. And various complications can arise from these complex operations, not limited to leakage and stricture formation, which then may beget need for more operations, which then can cause more issues related to abdominal adhesions, bowel obstructions, and things like that. And then, of course, risk of injury to the intestinal blood supply as you're purposefully splitting the blood vessels, the branches of the blood vessels, to be able to divide that larger lumen to make it into two smaller lumens. So those are serious considerations when looking at a patient, if they are an operative candidate, the type of operation to offer them. The other type of operation that we can do for intestinal lengthening is called a STEP. That's short for serial transverse enteroplasty. And what that is we take a dilated bowel, and I should also mention that bowel needs to be dilated to at least 4 centimeters, if not greater, in order to be a candidate for any of these operations. And we staple the bowel transversely in a stepwise fashion so that you create almost a zigzag-like channel that is by then default narrower and a little longer, providing additional length and forcing increased time for passage of the internal contents in the bowel. So all these staple lines then need to be reinforced so that we have less of a leak complication. So for this, you can have over 50% increase in residual bowel length with this lengthening procedure. And it's been shown that over half of these patients can be weaned from TPN after this procedure. And in this and the other bowel lengthening surgeries, certainly it's not a rapid necessarily decrease in TPN requirements. So when you're talking about an operation with these families, you also need to set their expectations for what to anticipate after surgery. When you compare the Bianchi or the Lelt with the step procedure, there isn't that much of a difference in the long-term outcomes as far as time off TPN, needing to go to intestinal transplant, need for reoperations. So a lot of times the operation that's chosen is also the operation that the surgeon has done the most and is most comfortable with their outcomes. There's a third type of lengthening operation that was described within the past 10 years called the SILT, short for spiral intestinal lengthening and tailoring. And it's what that is describing is taking that dilated length of bowel and making a spiral incision throughout that dilated length and then reorienting those segments of bowel so that you ultimately have a longer piece of intestine and getting it that way versus stapling it the stepwise way or dividing it completely down its center. So when in considering a patient then for the ultimate surgery, one could say, intestinal transplant, it actually has a little less to do with whether or not the patient has undergone these different surgical lengthening procedures and more to do with the other comorbidities and complications they've been dealing with just by having intestinal failure. So how progressive or advancing is their intestinal failure associated liver disease? Now, bilirubin greater than 4.5 for greater than 2 months, despite changing lipid scheduling, despite changing the type of lipid, be it SMOF or Megamin that you're providing with the patient's peritoneal nutrition, would be an indication, as well as any combination of lab values such as elevated bilirubin, low albumin, and increased INR, or other labs that are suggestive of portal hypertension. Another indication for pediatric intestinal transplant is thrombosis of 3 out of 4 central veins that are required that are options for the patient to get their line access for peritoneal nutrition. So do they have thrombos 3 out of 4 of the following? Their subclavian veins, internal veins, or their brachiocephalic. Had they required multiple admissions, specifically as described in the literature, 2 admissions to the ICU with the need for ventilator support or inotrope therapy because of sepsis or other complications specifically related to intestinal failure. So this brings in, again, the importance of central line care and the implications of a central line infection with these patients. Are they suffering from acute diffuse intestinal infarction with liver failure? And then if they have had intestinal transplant in the past, you can be a candidate for a second intestinal transplant. Overall, since the first intestinal transplants were done in children since the mid-'80s, there was a peak in the mid-2000s, but actually the rate of pediatric intestinal transplant are decreasing worldwide. And that is largely to the success of all these multidisciplinary intestinal rehabilitation programs that have come together and really improved the outcomes for these patients.
Okay, so in the second half, we're going to discuss the transition adolescent patient with short bowel to the adult care. So today, due to the advances of overall nutritional, surgical, and pharmacological strategies, 90% of the children with chronic conditions survive into the adult age, including the short bowel syndrome patient. So in US, 500,000 youths with special healthcare need transition each year. This is a big number, including those with short bowel syndromes. Although many short bowel patients will develop enteral autonomy through the childhood and adolescence. Some patients will remain dependent on home TPN and other complex life-suspending therapies through adulthood, so requiring transition to adult services. However, probably due to the rarity of the short bowel syndrome compared to other chronic conditions, no transition protocol are available addressed to this specific pediatric onset conditions. And unlike adult onset short bowel syndrome and intestinal failure, children with pediatric onset short bowel grow up, rely on the team of professionals and family care givers for their everyday survival. So as more patients with short bowel are now surviving into adulthood, patients and their family often struggle with transition to adult care. However, successful transition to adult care is not just one-day procedure, but a gradual process that requires preparing patients and family over several years. Therefore, we are going to talk about this process in the next few minutes.
So I'd like to take some time to talk to you about why the transition portion of treatment of short bowel syndrome is so crucial. So we all know that young adulthood and adolescence is a time of profound instability by necessity for all adolescents and young adults, not just those that have chronic health conditions. This is a time of transformation, and patients are leaping into the first throes of independence, or adulting as we so put it now. And those who don't do it well are primed to fail throughout adulthood. We need to set up our young adults for a life of success. And so for adolescents with chronic intestinal failure, what this means is that they now have to take over all of their care. And that means that not only do they have to graduate from their pediatric provider to an adult provider, but they also have to graduate from their parents taking care of them to learning to take care of themselves. So it's a multi-pronged step approach. So our youths must learn to autonomously manage a condition that up to this point has been carried out by their parents and caregivers. And for parents and caregivers, the process of supporting their child's independence and managing their own health care correctly is a very daunting process. And so successful transition really relies on the normalization of growth and development, promoting independent behaviors, improving compliance with therapy, and making a foundation for good health behaviors and consumerism. And that's what successful transition may look like. However, the failure of transition, what that looks like is non-adherence to medical therapy, leading to poor healthcare attendance and missing clinics and missing medications, and therefore deterioration of disease, possibly with life-threatening consequences. And so as you can see, this is a very critical time in which to get the pediatric to adult transition of care right in order to set up our young adults for a lifetime of healthy habits and correct health consumerism.
So as an example, I present a case here. Like this case, SF is a 13-year-old boy with short bowel syndrome. Initially, only 10 centimeter short bowel remaining, secondary to atresia and extensive bowel resection, and with jejunostomy, and then with home TPN support, and who, along with his parents, and had been followed in pediatric multidisciplinary short bowel clinic. But following the 3 bowel lengthening and surgical procedure and other nutritional and pharmacological intervention, his bowel has been successfully increased to 80 centimeters and has been weaned off TPN at age 4. However, following the anastomosis, the jejunal colonic anastomosis, and he has developed multiple complications as listed here, like including GI dysmotility, recurrent anastomotic ulcers, and very early onset IBD, intractable small bowel bacterial overgrowth, and feeding intolerance. And that requires daily or intermittent TPN and bi-weekly and monthly follow-up in our multidisciplinary short bowel clinic. So given the complexity of his condition, we feel it is very likely and he will need this long-term TPN support and also the intestinal rehab program support and through the adulthood. So, so how do we assist adolescents with short bowel and chronic intestinal failure as they transition from a pediatric to adult-centered model of healthcare? So this slide showed 6 steps to transition pediatric patient into adult care center. To implement each steps requiring a good coordination and communication between pediatric and adult healthcare provider. So so it is recommended we should begin the transition process in early adolescence at age 12 to 14 and continue this process into young adulthood at age 18 to 26. This would allow sufficient time for transition, preparation, planning, tracking, and follow through. So I will, together with Dr. Pham, go through these 6 steps one by one. So this is this slide showing the step 1 is so in this step, the pediatric provider will develop transition and care policy guide with input from youth and the family and not describe approach to transition, address privacy and consent, and also clarify the age for transfer to adult clinicians. We will educate all the staff, including about the practice approach to transition and distinct role of youth and parent and pediatric and adult clinicians in transition process, and not also taking into account the cultural preference. We will display the transition and care policy guide somewhere also accessible in the practice space and discuss and share with youth and caregiver and beginning at age 12 to 14 and regularly review as part of the ongoing care. So a transition coordinator in this setting of multidisciplinary clinic may be best prepared for the direct transition of youth with short bowel syndromes.
Okay, so to kind of build on what Dr. Chang had built, this first step really doesn't involve adult providers as much per se. At this point, the patient is around 12 to 14, and that's when the transition process really should be introduced. And what that really entails is really making sure that providers are on the same page with the patient and their families with what their goals are in this transition process. And at this point, the adult providers really just need to be in the loop about what the patient's goals are, kind of understand what the transition process looks like from a big picture perspective, where your center is, and work in tandem with the pediatric providers to make sure that the ground is set and paved and ready for when that transition actually happens. So there's really not much to do from an adult, the adult side of things, but more so just make sure that you are kept in the loop as the patient grows and gets closer to transition.
So in step 2, this is tracking and monitoring. The main job is to establish criteria and process for identify the transition age, use, and develop process to tracking patient progress through each transition steps, integrating with the electronic medical record and when possible.
Again, at step 2, adult providers really aren't involved in patient care so much as just being familiar with the tracking modalities involved with tracking progress of transition. There are a variety of surveys and measurement tools available to track progress, and I would just suggest that adult providers be familiar with these tracking devices and again, continue to be good communicators and be collaborative with your GI colleagues or your pediatric GI colleagues.
So this is this slide showing the step 3 is transition readiness or orientation to adult practice. So the pediatric provider in this step will conduct now regular transition readiness assessment, beginning again at age as early as like 14 to 16 years old, and to identify and discuss with the patient and caregiver their need for self-care and then how to use health care services. So transition patient and also from pediatric to adult enteral and parenteral formula when possible and when appropriate, and offering education and resources on needed skill identified through this transition readiness assessment.
One thing that has to be remembered as part of the transition protocol is we have to train and teach these young patients how to manage their own parenteral nutrition or enteral nutrition needs and help them understand that if not managed correctly, complications that can arise, some of these complications possibly being life-threatening. I teach them things like how to care for their sites. They're on tube feeds for enteral nutrition. I'll teach them how to care for the G-tube management. I teach them how to manage and adapt their enteral nutrition if they start to have side effects, so that as they take over the care from their parents and become responsible for themselves, they understand what it takes to be responsible for their own nutritional and or intestinal care.
At the point of step 3, adult providers really should be giving an opportunity for their patients and their families to interface with the adult world. At this point, it would be a good idea to have welcome packets ready and have contacts ready in case the families and the patient really wants to start asking questions or providing introductions. And then just provide an FAQ to patients, and that way they start to feel more comfortable with the process of transition as we get closer and closer to the actual transition into the adult world.
So in step 4, so transition planning. So the pediatric provider's job is to develop and regularly update the plan of care, preparing the patient and caregiver for adult approach to care, and determine the need for decision-making support, and making referral to legal resources when appropriate, and planning for optimal timing of transfer, and assist the patient in identifying an adult clinician and provide a link to insurance resources, self-care management information, and community support service, and obtain consent and for releasing of medical information.
At step 4, adult providers at that point really need to be prepared to take over care of the patient. At this point, if there are any questions about the patient's medical history or ongoing care, this is the perfect time to collaborate with your pediatric GI colleague to get any questions answered in preparation for your first visit with the patient and their family. Make sure you have a pre-visit appointment reminder for your patient. For example, if your clinic is in a location that's different from their pediatric GI provider, make sure you make this very apparent to patients and their families so there's no confusion or getting lost before their first appointment, which can be pretty startling and daunting. And then this would be a good time to maybe even, introduce yourself via email or phone call to kind of make everyone feel a little bit more comfortable before your first meeting. So this is all just setting the tone for your very first visit.
Again, for the youth with short bowel syndrome who dependent on TPN, it's important not forget to schedule 2 to 4 shared consultations. So step 5, transfer of care or initiate a visit in adult service. So in these steps, And the pediatric provider now will complete the transfer package, confirm the date of first adult clinician appointment with patient, and then prepare letters with transfer package and send it to the adult clinician and confirm receipt of transfer package and communicate with adult clinicians. And also confirm pediatric clinician responsibility for care until patient is seen by adult clinician, and then we can transfer the care.
So for adult GI providers, this is the point at which you finally interface with patients and their families. And I think for me, the biggest point of contention or worry is, how are pediatricians different than adult doctors? And there's a lot of differences. And I always want to make sure that I start to introduce the whole idea of differences in monitoring for fertility, differences in cancer surveillance, differences in the amount of procedures we do, for example, more frequent colonoscopies and endoscopies. And these are all differences that need to really be gone over in detail so that there's no confusion or concerns. And then this is a good point at which to go over any of the transition readiness scales that were filled out by the patient and identify the deficiencies that the patient or their families have that could help with improvement in self-care. So if there are deficiencies, make sure you offer education and resources on needed skills, and then review the health priorities of the patient and their family, and make sure that you're all on the same page in terms of goals of care. And then lastly, update and share with the young adult and their medical summary and emergency care plan in case anything does arise after hours.
So the last step of transfer care is step 6 is the transfer completion, and for the pediatric provider, will contact the patient and their caregiver about 3 to 6 months after the last pediatric visit to confirm the attendance at the first adult appointment, and also make sure to obtain feedback on their experience with transition process and communicate with adult practice and confirming completion of the transfer, and offer consultation assistance as needed, and build ongoing and collaborative partnership.
So for adult GI providers, at this point, the umbilical cord has been cut, so to speak. The patient is completely transferred over to your care, hopefully. And at this point, I always want to make sure I tell the patient that I continue to collaborate with the pediatric GI providers and their previous team to make the patient feel as if we're all a family that is collaborating and getting the best care for them. And so it's not uncommon for me to go back and contact the pediatric team to get any reassurance about next steps, or if there's any clarifications that are needed. So I make sure to remind the patient all the time that there is frequent collaboration. And then I also want to make sure that at this point, the patient is also graduating from care from their parents, hopefully as well. So the graduation from pediatric provider to adult provider has been made. The next step is graduation from the care of the patient to care of the parents taking care of the patient to the patient taking care of themselves. And so at this point, we have to make sure that if the patient is comfortable with their parents or their caregivers still being a part of their care, that proxy forms are signed. And then as care is ongoing, I always make sure to elicit feedback from patients and their families to make sure that things are going as they had anticipated, and that there are no concerns that need to be answered as the transfer is complete. So lastly, to get close to wrapping things up, I wanted to go over what the potential barriers to optimal transition of care may be. So there are multiple different ways that there could be hiccups along the way in transfer of care. The patient or parent and caregiver may be reluctant to transfer from pediatric care to adult care, as this is just a whole different world. It may be a whole different location, and the pediatric care provider has been a part of the patient's care for upwards of a decade, and so there's a lot of familiarity and comfort there, and going to a new provider is very daunting and scary. There is often inadequate communication from pediatric clinicians to adult providers. For example, if there may be lack of physical records, there are no op notes might be missing, or procedure reports might be missing. If it is actually a location that is remote from your center, you may not actually have an ongoing relationship with the pediatric care provider, and that can lead to difficulties in communication. There may be difficulty in locating adult clinicians who have specialized knowledge about youth with pediatric onset short bowel syndrome. Other barriers are that patients may not be adequately prepared to care for their home parental nutrition or enteral nutrition on their own. There could be loss of insurance coverage as the patient graduates out of their parents' insurance. There may be lack of quality social support as the patient has moved location or has gone on to college and lost their previous social support. And then lastly, there may be a lack of awareness of community resources for young adults with short bowel syndrome and or chronic intestinal failure. And this is where you as a provider should step in and provide patients with the resources that they may need. So next we have Kimberly Iglesias, who is a pediatric social worker, who will discuss with you some of the myriad of resources we have available for our patients.
And so we have some examples of some resources that are out there, all free, online, that you can either refer your families to or utilize yourself when trying to sit and do patient education. So one of the things that we've talked about is that period of going from adolescent to adulthood and all of the things that need to be learned. So every person has to learn how to balance a checkbook and do their own laundry and make meals for themselves and all of those skills. And here's a resource called overcomingobstacles.org that helps prepare some of those problem-solving skills training modules. So if a patient's interested in kind of honing those skills, this is a great resource for that. And as we've mentioned, patients that do have a chronic medical need have even more at stake if they're not able to master some of those skills. So we just want to make sure that families and the patients have all of the resources available to them to be able to make that transition as smooth as possible. There's also the Oli Foundation is a wonderful website specifically for patients that are on IV nutrition or enteral feeding nutrition. There's an online forum where people can support each other and kind of identify with one another in a shared experience of what they go through. They share resources. There's scholarship opportunities that are listed on the website. All kinds of wonderful things to help support patients as they are, again, moving in from being an adolescent and into an adult. And here's just a few other resources. The Sick Kids website, I believe we have a example of what they provide. There's this health passport that a patient can fill out, and at the end of it, they're able to print that off, and it's this very handy dandy one page, has everything that is important and pertinent about their medical history, contact numbers for physicians, previous surgeries, everything that they would need to know. And instead of having a huge notebook of all of that information, this allows for that to be printed off all in just 1 to 2 pages. So these are just some of the online resources that are available that we wanted to cover.
All right. Well, thank you everybody for attending this comprehensive review on treatment of short bowel syndrome. I just wanted to lastly focus on the fact that as you now have realized, this is a very, very complicated, potentially complicated process. And it really it has a lot of moving parts and it has a lot of team members. And so it would be very important to designate one team member, a care coordinator, transition coordinator of sorts, or patient navigator, to really coordinate all of the paperwork and all of the moving parts of this, complex process. And so just make sure that either, if you don't have that person, to designate a team member that can keep an eye on all these moving parts. So with that, I'd like to wrap things up, and thank you everyone for listening.
This activity is certified by the University of Florida College of Medicine for Physicians and by Medical Learning Institute Incorporated for nurses and pharmacists. This activity is developed in collaboration with our educational partner, PVI, Peerview Institute for Medical Education.